Today, I'm delighted to welcome Professor Sasha Shepherd, Professor Graham Ellis, and Dr. Maggie Westby to present some of the latest evidence on home-based alternatives to hospital care from 3 evidence reviews. Their presentations will explore what are the key elements of hospital at home and virtual wards, what's their impact on outcomes, what's their impact on service costs, and what factors contribute to their success. Our first talk is a joint presentation from Professor Sasha Shepherd and Graham Ellis. Sasha is a professor of health services research at the University of Oxford, and her research uses epidemiological methods, randomized trials, and evidence synthesis to answer pressing health service questions with a focus on population aging. Sasha was the chief investigator of an NIHR-funded randomized trial of hospital at home versus hospital admission, and she's recently published 2 Cochrane reviews on hospital at home. Professor Graham Ellis is a geriatrician in central Scotland and was a clinician with the hospital at home service. He's an honorary professor at Glasgow Caledonian Universities and was appointed Deputy Chief Medical Officer for Scotland in 2021. This joint presentation focuses on hospital at home services, including effectiveness, costs, and factors for success. Over to you, Professor Shepherd and Professor Ellis. Thank you.
Thank you very much, Candice, and good afternoon, everyone. It's a delight to be here. As Candice has introduced, my name is Graham Ellis. I was a clinician in hospital at home and was also involved in the research that Sasha led. But I want to start, if I can have the next slide up, with a little bit of context from a clinical perspective. So I want to tell you about Jack. Jack was a patient I met early on in my experience in hospital at home, and in many respects, for me, illustrated exactly what hospital at home is about. Jack had pneumonia, and as a consequence of his pneumonia, developed uncontrolled atrial fibrillation with a heart rate of 135. And as a consequence of that, had some cardiac decompensation. He developed some cardiac failure. As a consequence of that, he was unable to walk more than 6 feet, was unable to get out of bed and go very far, so he couldn't go to his bathroom across the landing. Now, in a normal context, if Jack was admitted to hospital, he would have to wait to see his GP or certainly have to wait for an ambulance. He would then be transferred to the ED or to an admission ward. But Jack could not go home until his heart rate was stable. And because he would have to have his symptoms controlled in order to manage the stairs in his house to go upstairs to the bathroom, he would not be able to go home until that was done. So in other words, his stay in hospital might be several days until all of that was sorted. Now, with hospital at home, we were able to give him medication for the pneumonia and for his heart rate. We gave him a commode for overnight, which is not glamorous, but that's exactly what he would have had in hospital. And as his symptoms were controlled and his heart rate came under control, he was more able to walk to the bathroom. And our therapists were able to go in and see him at home and manage to train him regaining strength on the stairs to manage up and down. So Jack's case for me illustrated in a very simple and certainly not the most complex case exactly how hospital at home can work as an alternative for patients who require it. Next slide, please. So hospital at home is defined broadly in a similar fashion by these main descriptors. It is hospital level treatment by a hospital level clinician for a condition that would require a hospital. That would include interventions and diagnostics that you might expect in a hospital setting and would be managed by a multidisciplinary team. In other words, much of what you would expect to find in a hospital setting for an acute condition like Jack's, but delivered in an entirely different setting or context. Next slide, please. And I'm grateful to Healthcare Improvement Scotland who created this diagram, but I think it's a really important one. Hospital at home sits within a context of care or a continuum of care that's really important to try and illustrate where it fits in our current healthcare setting. So everything from self-care for conditions I can manage myself, for people I can access easily in the pharmacy and so on, to primary care clinicians who can treat me for a condition, to the more complex multidisciplinary community rehabilitation that you might be able to get, to those elements of care which we've called enhanced care, but effectively describe interventions which are intended to proactively try and mitigate against hospital admission for people who are frail or at risk of admission, or help them return home from hospital. And so hospital at home sits at the level where people actually require hospital level care, but is delivered at home as opposed to in a bricks and mortar setting. Next slide, please. Now, I mentioned Jack's story. Jack is the sickest or most complex patient we've treated, and this list of conditions is not exhaustive. It's taken from Healthcare Improvement Scotland's own website and describes many of those conditions that older people with frailty or complex needs are often admitted to hospital for. And often you would see these acute medical conditions alongside frailty syndromes such as delirium, falls, or acute functional decline. Now, I'm not going to labor this because the slides will be available, but it's meant to illustrate the sort of regular referrals that would come into a hospital or home service that we would frequently see. Next slide, please. And in terms of the interventions, I referenced the idea of hospital-level treatments and diagnostics available at home. Many more of these are more portable. We now have point-of-care diagnostics that can be done at the bedside. But treatments such as oxygen and intravenous treatments that you might expect to see in a hospital setting are now delivered in hospital at home. And these interventions don't necessarily describe all of what secondary care, hospital level care is about, but are certainly part of that element of acute care that is appropriate for patients who have high acuity clinical conditions. So I'm really just trying to set the context clinically for what hospital at home is, but at this point I'm going to hand over to Sasha to talk about some of the research findings. Thanks, Sasha.
Thank you, Graham. So I'm going to provide an overview of a randomized trial which Graham was involved with, along with many other people that we started publishing from around sort of 2019 to 2022. All the findings of the trial and the methods are described in detail in this NIHR journal publication. So in brief, we recruited participants who are age 65 and over from 9 sites across the 4 nations. In fact, the average age of the participants recruited to the trial was 83 years old. I'm not going to run through these conditions, very similar to the ones that Graham's described, and this is a list of our exclusion criteria. Next slide, please. So key features of hospital at home, again, very aligned to Graham's description, but just as a run over the features assessed in this randomized trial. Clinical responsibility of the hospital at home schemes we evaluated, and I should add that they were all established for various periods of time, but we didn't evaluate a sort of brand new hospital at home scheme in the trial. So consultant geriatrician led was the main clinical responsibility in all the sites apart from 1. The governance structure sort of fitted with that and based in the acute hospital directorates in all sites apart from 1. The main source of participants recruited to the trial was from the acute medical assessment unit, but they could be referred from other locations. And patients referred to hospital at home were assessed within between 1 and 4 hours, depending on their condition. All patients were reviewed daily, either virtually or face-to-face, and hospital at home was organised around the principles of comprehensive geriatric assessment. And as I mentioned, the hospital at home schemes were sort of consultant geriatrician led with working with the multidisciplinary team. Next slide, please. So here's an infographic from our clinical findings paper, which was published in Annals of Internal Medicine. So I'm just going to use this actually to briefly describe the design of the randomized trial. So we recruited over 1,000 people, as I mentioned, average age 65, and participants, after they consented, were randomized to hospital or hospital at home. We used a 2-to-1 randomization ratio, and that was sort of a online randomization system. Our main outcome was living at home after 6 months, and we found no difference in that. So living at home is a mix of being alive and not being in residential care. Next slide, please. So secondary outcomes, there was an increased risk of being transferred to hospital at 1 month for those allocated to hospital at home. As I mentioned, there's no difference in mortality at 6 months. And we found a reduced risk of delirium in the hospital at home group at 1 month, and similarly reduced risk of long-term residential care at 6 months. Next slide, please. In terms of cost, we found that hospital at home was less expensive than hospital admission. On average, this was around £2,000, but the big caveat with this is there was considerable uncertainty in these estimates. So there was a range of values that were compatible, including a very small difference in cost. Next slide, please. Impact on unpaid caregivers. So we did a full process evaluation where we interviewed patients, caregivers and staff, providing both hospital at home and hospital. And the main findings from the process evaluation for caregivers was there was concern around caregivers' role around monitoring at night. And this was linked to safety. And the examples provided were for people with delirium. Some caregivers felt there was a lack of formal recognition, and they felt that that might have been improved by access to more information. And there was a loss of privacy, or for some people, they felt there was a loss of privacy in the home. Next slide, please. So first, the first Cochrane review I'm going to briefly report on. This is, we updated and published an update in 2024. We included 20 studies, which included the randomized trial I've just covered. And here we found, similar to the randomized trial, that in terms of sort of mortality, it was similar between groups, that's hospital at home and hospital. We found very similar results for hospital admission, but the caveat here is that the trials use different lengths of follow-up. So hospital admission was measured between 3 and 12 months, and the date of the trials also varied hugely, so published between 1999 and 2021. There was increased patient satisfaction, and residential care was decreased at 6 months, similar to the trial. Treatment costs also reduced, but again, huge caveat, different methods of costing, and the trials spanned a long period of time, again from 1999 to 21. Next slide, please. Final Cochrane review. This is a qualitative evidence synthesis where we included 52 studies from 13 countries. This was led by Jason Wallace and colleagues in Australia. We included interviews from 900 patients, over 400 caregivers and over 600 service level staff. Next slide, please. So I've summarized the findings from this synthesis in 2 slides, and I've done this by really a summary of the factors that facilitate implementation, and the next slide is the barriers. So in terms of facilitating implementation, a sort of core finding around prior to implementation was early engagement with hospital and community providers. A finding around successful implementation that a number of studies reported was that hospital at home staff having acute care experience provided a confidence for working in hospital at home, and that teamwork and task sharing were essential. The perceived benefit was that by maintaining routines in the home facilitated faster recovery, and there were around sustainability. Time-limited service was seen as crucial, so if a hospital at home service was provided for a long period of time, it was unlikely to be substituting for hospital care, and that there was a need across all studies actually for expanding referral routes. Next slide, please. In terms of sort of pre-implementation, barriers reported were around the legal, regulatory environment and funding. There was difficulty sometimes identifying suitable patients, and then due to a lack of shared records, there was a risk that assessments could be duplicated. Perceived trade-offs, as I mentioned, was fairly uniform, was around impact on unpaid caregivers, and that it felt that the sustainability of the hospital at home would be improved if unpaid caregivers could be supported. And then a few studies mentioned training issues and career development opportunities for hospital at home staff. Next slide, please. So final slide, just to really acknowledge the support of a huge number of people, both for the trial and for the Cochrane reviews. And there are many others whose names couldn't fit on the slide. Thank you.